There, hi everybody, welcome to the webinar.
Can you guys hear us okay?
Yes.
Perfect.
All right, great.
Thank
So
you.
if you have any questions, you can always put them in the chat box and we'll be sure to answer them. But I'm Dr. Horn.
Dr. Vivekanandan.
And we're going to talk about influenza today.
And you know, the influenza season is starting, so I think this is the perfect time to kind of start talking about this. So I kind of wanted to kind of update you guys about where to find influenza data. So every week, the CDC updates weekly the influenza activity in United States. And so as of, they had, you know, when I went in this morning, as of November 16th, they had updated data at CDC. So it's a really good resources. If you type in weekly US influenza surveillance report, you could kind of keep an eye on how the influenza activity is going. So next slide. This slide is kind of nice. It shows where the influenza activity currently. So, you know, it sounds like, looks like some of our southern states are having a higher amount of influenza activity. And other areas, it's still pretty green and light green, so very minimal activity still. It's kind of surprising because last year, around this time, we started seeing a lot of cases. We had early influenza, but I feel like this year it's kind of starting late, the trend.
Yes, and I like these graphs, and every year they come out, and I think they update this about every week, and every week they show kind of the influenza moving across the country, and they show kind of where it's sporadic, and then it's kind of all over, and then the graph goes completely one color, where it's just essentially everywhere.
Because last year around this time, it was completely one color everywhere. Yes. It was very high activity. So this year, thankfully, it hasn't gotten that high yet.
Right, and I think one of the main things we're going to be talking about this talk is the importance of getting a flu shot.
Yes.
And so I wouldn't follow, you know, the activity and how the activity is doing as far as the need to get a flu shot. I would still recommend getting a flu shot to everybody, even early in the season would be okay.
So this is a really nice graph showing that laboratory confirmed influenza cases this flu season. So as of now, they have had about 393 influenza cases that are hospitalization for patient. From that, about 62% of the cases were influenza A, and then influenza B was about 36%, and about 0.8% of the patients had co-infection with A and B. But it looks like both strains are in the community, A plus B. And if you look at the graph, you know, our high-risk patients that we always talk about, elderly patients over the age of 65, in this graph, it's already peaking. And the second highest is our kiddos less than 4 years of age. So their numbers are going pretty high already compared to the cases that we have. So something to keep an eye on. And they also report about the pediatric deaths that have happened due to influenza. So if you guys look from 2017, 18, 19, and 19, 20 season, last year we had about 143 deaths attributed to confirmed influenza. And this year we have already had some multiple deaths already, about 4. So that's something to, you know, make sure, and this is one of the reasons why we need to vaccinate everybody, including our kids. This is a really nice graph. So this graph kind of tells us like the influenza curve is the black. With that, the red curve is pneumonia cases. So influenza with pneumonia, where are they right now? Sometimes during peak influenza seasons, your pneumonia cases goes up even higher. And we're going to talk a little bit about what kind of pneumonia you get after influenza. But currently, about 5.2% of deaths occurring during the week ending of November 9th were due to pneumonia and influenza. This percentage is less than the epidemic threshold, but we're kind of slowly getting there.
So signs and symptoms, so fever. Fever is not always present, especially in the elderly. So this is good because sometimes when people call, they'll tell us that the patient's not having a fever, so they're not suspecting influenza. So it's a good thing to kind of keep in mind that they don't need to have a fever. muscle aches, and muscle aches, kind of myalgias, are, I think, kind of the hallmark of influenza, where they get kind of generalized muscle aches, fatigue. So they could have headache, lack of energy, dry cough. In general, it's hard to differentiate influenza from other things sometimes. There's kind of influenza-like illness. And so when you see somebody and you're not sure if it's influenza or not, it's important to treat them like influenza, and especially if there's a lot of influenza in the community. But
you know, I always say, like, if it's during the influenza season, if you don't have a rapid test, just treat the patient with, you know, Tamiflu and antiviral medicine and get them better, because, you know, it's higher, you know, once we have peak season, it's going to be, most of the patients will have influenza. How do you spread influenza? So virus spreads mainly by droplet. So from people's cough and sneezing and talking. Droplets can land in the mouth, nose of people who are nearby. So usually the influenza droplets, when a droplet precaution, if you're away 3 feet and away, less likely that you could get contact. But if you're 3 feet or closer to a patient with influenza, high likelihood that you can get influenza and have the infection. Less often a person might get flu by touching surfaces, but that is a possibility too. And this is why it's really important to do good hand hygiene to make sure we keeping our hands clean and not spreading. Droplet precautions. So we always get asked, what kind of precautions do you use in the hospital, in the clinic? So for influenza, it's droplet precaution with wearing a face mask, and then doing good hand hygiene when you see the patient, after you seeing the patient.
And another common question we get is about, what about droplet precautions for coronavirus or other influenza, or sorry, other viruses that we find patients to have? So what do you recommend about coronavirus or other viruses that come up?
So sounds like our slides are not going forward.
Yeah, I'm not sure why that would be.
Okay, thank you.
Okay.
Okay, perfect. So droplet, so
like coronavirus and other questions, because other viruses can actually make people very sick as well, and then they can get a bacterial infection on top of those also. But as far as spreading in the hospital and precautions, yes, coronavirus and other viruses that come up, rhinovirus.
So you know, like I'm sure a lot of you guys have the respiratory pathogen screen, which picks up for all the different types of viruses now where we have. And when we look at CDC, they recommend when you have any of those viruses in the hospital, ideally the patient should be in droplet precaution so you don't spread it to other patients. So for influenza, high-risk patient for developing influenza-related complication. So asthma patients, but also who else are the other high-risk patients? Definitely kids less than 5 years of age, but especially our younger kids less than 2 years of age. Our elderly patients over the age of 65. So if you look at the influenza-related deaths annually, over majority of the deaths that happen are in our elderly patients over the age of 65. Women who are pregnant are really high risk, but also postpartum within the first 2 weeks of delivery are really high risk. And also there's some American Indian Native, Alaskan Natives are at high risk for influenza. If your BMI is greater than 40, you're at high risk. And if you have chronic care facility or nursing home patients are at high risk. Another thing to also think about is if you're in a long-term care facility also, it's easy to spread around to the other residents at that facility. So it's really important to vaccinate and look at these high-risk patients.
So those were high-risk patients, and then you have high-risk conditions.
Mm-hmm.
So really, when I think of high-risk conditions, there are so many high-risk conditions that really any chronic lung disease puts someone at kind of high risk. So asthma, neurological, chronic lung disease, heart disease, blood disorders. I mean, there are so many things that it's really important to make sure that all of your patients have a flu shot. And when influenza is widespread, so as far as testing goes, influenza-like illness, so ILI, can be assumed to be influenza without testing. So when influenza is kind of all over the community, you want to assume it's influenza and treat as if it's influenza without testing. So if it's all over the community, if you do a test, if it's a negative, it's most likely a false negative because there's so much in the community. So I wouldn't recommend testing. I'd recommend just treating.
So to go off that point, you know, a lot of the places in, you know, primary care clinics, urgent care, ER, we're still using antigen testing. And the problem with antigen testing is only like 65%, sometimes 70%. It can detect the virus. But, you know, if you have a PCR test for influenza, which is fantastic, it can detect up to over 95%. But when we do the rapid testing with the antigen, the problem is you're going to miss so many cases during the season. So I think, like you said, it's really important if you have high degree of clinical suspicion, treat the patient with antivirals. Here's the
yes, and here's the PCR over rapid testing.
Yeah, so PCR testing is fantastic. Very over 95% able to detect the influenza virus. Some places we have influenza PCR by itself, and some places will have it with the respiratory pathogen screen. Either way, it's a PCR test, whichever route that you guys use. If you have that, it's a good test to use. You know, sometimes what happens is in the hospital setting, let's say you have you're admitting a patient into the hospital, and in the ER, you check the patient with the antigen test for influenza. It comes back negative, and then you admit the patient into the hospital without putting them in isolation. And then now you could spread it to other patients. So what we have, some of the good practices to do is, in the ER, and if the patient is getting admitted in the hospital, you still, if your degree of suspicion is really high, you keep them in isolation. Either you treat as influenza or you do a PCR test to make sure is it influenza or not, so you don't expose your other patients in the hospital.
Right, so it's testing so when the antigen is negative, then doing a PCR.
Exactly.
So that's a way to reduce costs and not do a
Exactly.
PCR on everybody.
Yeah.
That's a good way to do it. And then treatment. Start antiviral treatment as soon as possible for adults and children when documented or suspected influenza. And irrespective of influenza vaccination history or who meet the following criteria. So as soon as the patient, you're seeing a patient with influenza, if they're in the hospital, you want to make sure you're treating them, and it doesn't matter how long they've been sick. So in the past, well, really it's been patients in the clinic setting. In the clinic setting, when they come in and they've been having symptoms for greater than 48 hours, then the question would be, do they benefit from getting treatment or not? And if it's been over 48 hours, some studies have said that it doesn't really help too much. But really, you also need to look at the patient. Is it a high-risk patient? Do they have a lot of those high-risk conditions? And I would consider treating them anyway, even if it's been going on for 48 hours. If it's a young, healthy person and they don't have any of those comorbidities, they're not high risk, then you can kind of say, well, maybe you don't need to treat.
For me, you know, the new CDC information also says that anybody who gets admitted to the hospital, anybody that gets sick enough to get admitted to the hospital, doesn't matter the duration of influenza, even if it's 5 days, we should give them antivirals. One thing to remember is if your immune system is not very good, and you know, elderly patients, there have been studies where even they could replicate the virus up to 14 to 21 days. So in my mind, if somebody, like you said, all these chronic conditions, high-risk patient, even after 48 hours, outpatient or inpatient, I would want to treat them if they could tolerate the antiviral.
Right, and so influenza is kind of one of these things where it can make someone very sick, but it can kind of start out slowly. So when you're seeing the patient, you may say, oh, they're not that bad, and then they continue to deteriorate while they're in the hospital. And so any patient that comes into the hospital and you're suspecting influenza, I would go ahead and treat.
Yeah, and like the mechanism behind it is you give the antiviral, you stop the replication, which stops further inflammation in your body, and it doesn't cause more immune system to go down, so you get other infections. So sooner you could stop this virus from continuing to replicate, the better off the patient is. So I would be very cautious about this like 48-hour cutoff and kind of think about the patient.
Right. So anyone that, I guess to summarize,
Yeah.
so anyone that comes into the hospital with influenza or suspected influenza, I would go ahead and treat them.
Yes.
Right. And antiviral treatment is recommended as early as possible for any patient with confirmed or suspected influenza. And so that's again, you don't want to have them come to the hospital and say, well, I think they're doing okay, let's not treat. It's better to be aggressive up front and de-escalate later. So if they're hospitalized, they have severe or complicated progressive illness, is at a high risk for influenza complications.
Yep. So we want to kind of talk about now, when you have influenza, you could also get bacterial pneumonia on top. So in here, you guys see the graph where what is the most common bacteria if you're in the outpatient setting, inpatient setting, or in the ICU setting. Usually what we worry about is strep pneumo. And depending on our patient, you get some of the atypical bacteria, mycoplasma, Haemophilus, chlamydia, and viruses. If you're an inpatient and not in an ICU, you have a couple more Legionella and think about aspiration. And if you're in ICU, then you think about Staph aureus. But this is for a normal person who has community-acquired pneumonia. What happens to somebody who has influenza and has pneumonia? This influenza can cause pneumonia at the same time or a week or two later after having the influenza. So it's really important to have high degree of suspicion for the following bacteria on the next slide. So if you have influenza, you're at high risk for Staph aureus, strep pneumo, Haemophilus influenza, but Staph aureus goes up. So MSSA and MRSA are at high risk for patients to have.
Yes, and so these are, so up until these slides, we were talking about influenza. Now we're talking about influenza pneumonia and secondary bacterial infections due to influenza. So, and these are, and the new community-acquired pneumonia guidelines, they kind of go over it, and they recommend starting antibiotics. Well, I'm kind of skipping ahead, I guess. They recommend starting antibiotics for anyone that comes in with influenza and pneumonia.
Yes.
Even if you just suspect the pneumonias all related to the influenza and you're not suspecting a bacterial infection, they still recommend starting antibiotics because it's because the bacterial infections, the secondary bacterial infections, pneumonia, are so bad, and they have such high mortality for the patients that they recommend starting antibiotics for all patients with pneumonia and influenza.
And like the graph that we were showing earlier, where pneumonia with influenza mortality is about 5%. So it happens quite often, and so it's really important. If you guys worried about somebody having influenza, we get a chest X-ray, and there's infiltrates. Like here, it's important to treat the patient initially broadly. We're going to get into what treatment, and then of course work them up as well. So if, some of the things that I do for working this up is getting sputum cultures. I do urine antigen for strep pneumo. You can also do for Legionella. So those are very helpful to kind of guide you to see if you have a secondary bacterial infection. But if you have any type of lung infiltrate on a CT or a chest X-ray, like Dr. Horn was saying, it's really important to add antibiotics.
And here we're stressing influenza. This can also happen with respiratory syncytial virus and other viruses where you can get a viral pneumonia and then a bacterial infection on top of it. And with this, so when you see this, this is the classic picture of an influenza pneumonia. So this is patchy alveolar infiltrates. So you get kind of this patchy picture kind of all over. And so with this, you'd say maybe this would be more likely viral, whereas this picture where you get a consolidation would be most likely a bacterial pneumonia. And this would be the classic bacterial pneumonia. Now, when the patients first come in and it looks like a influenza viral pneumonia, sometimes the patients, you might say, well, that's a viral pneumonia and they don't need antibiotics. And then what is seen, what's kind of presented as the classic picture of getting a secondary bacterial infection would be the patient comes in, they have an influenza pneumonia, they get treated with oseltamivir, they start to improve, they're doing better, and then all of a sudden they do much worse. All of a sudden their white count goes up, all of a sudden they have a leukocytosis, they have a fever, and they're much more sick all of a sudden. And then you would suspect a bacterial infection on top of it. And really that's why they want to start antibiotics from the start to try and prevent that.
Yeah, and another interesting thing to go off of your point is that, sometimes we don't think about it. If you have influenza even 2 weeks ago, 3 weeks later, you're still at high risk for developing staph and strep pneumonia.
Yeah,
so it's really
point.
Yeah, so it's really important to get the history from the patient and know, okay, they recently had influenza, so this patient has high risk for staph pneumonia.
Right, and this is, when I think about this topic, there's something called anchoring on a diagnosis, where if a patient has influenza pneumonia, then you see the patient, it's really easy to look in their chart and say, oh, this is all influenza, and not work it up any farther. And that would be an example of anchoring, where you anchor on a diagnosis and you don't really work it up because your partner or whoever saw the patient last time worked it up. So you might say, oh, this is all influenza, we don't need to worry about it, we don't need to order any tests. And then, so a patient kind of gets labeled as a diagnosis, and then they don't get worked up. And there's kind of a saying, I think, make your own mistakes. Where it's kind of, they might have just, one thing, or they might have something else, but if you work it up yourself and then decide that they don't need antibiotics, that's kind of different than just saying, well, the last person worked it up, so I don't need to look into it or something.
So the trick is sputum cultures are helpful, which we don't get enough of. So sputum cultures, urine antigen, and you could also use nasal MRSA screening too if you cannot get sputum, to see if they're colonized with MRSA. So there's different tools for you guys to figure out what antibiotics to use.
Right, and the important thing, especially with pneumonia, is how is the patient doing? So if they're continuing to improve, you may not need to make changes, but if they're getting worse, it'd be a good idea to consider making a change.
So what antibiotic should I use if I suspect a secondary bacterial infection associated with influenza?
So let's see. So what are the main things that you're trying to target as far as bacteria? So strep pneumo. So we were talking about the importance of strep pneumoniae, and whatever you give, you would want to make sure you cover the most common bacteria. So strep pneumo and Staph aureus, which moves way up in the which bacteria are causing the problem in influenza. So whatever you choose, you want to make sure you cover strep pneumo and Staph aureus in your area, and not only MSSA but MRSA in these sick patients.
What antibiotic should I use if I want to avoid vancomycin due to HKI? So Ceftriaxone plus doxycycline. So let's say that you have a patient coming in from the community. They recently had influenza. Now you're worried about pneumonia. So I think of it as, our community-acquired pneumonia treatment regimen is you do ceftriaxone and azithromycin. You take the azithro and you replace it with doxy, where the ceftriaxone is covering really well for your strep pneumo and other organism, and your doxy is now covering for atypical, but the biggest, it's covering for your MRSA, MSSA. So this is a really nice combination to do during influenza season for pneumonia, doing ceftriaxone plus doxy.
Right, and so doxycycline covers, you'd have to look at your antibiogram in your area if you're able to have an antibiogram. So doxycycline covers really well for MRSA for us.
Yes. In our region, in Nebraska, doxycycline has over 90% susceptibility for MRSA, and then Bactrim has over 90% as well.
Right, so Bactrim is another good choice. Here it's with AKI, but that's why we have doxy here, but Bactrim would be a good alternative. And then ceftaroline, so good as strep, good staph, and it includes MRSA coverage. And if you're looking to kind of avoid vancomycin, ceftaroline would be a good alternative. And then we also have linezolid here.
Yeah, and linezolid is also one drug which will cover your strep and your staph, so it works great. Just, watch out for all the side effects from linezolid, but it has good coverage.
Right, and if you're using linezolid kind of shorter than about 10 to 14 days, then you should be okay.
You should be okay.
Right.
And your pneumonia treatment is 7 days anyways, like a short, so I think you should be okay with it.
Right, there are a lot of concerns with linezolid, but if you're going to use it just for kind of a short course, I consider it a good option here, because I would rather make sure that you cover MRSA in these patients. Yep.
What dose of ceftriaxone do you recommend? So usually we give ceftriaxone 2 grams per day. And if you have a really sick patient that is in the ICU on pressors, or they have meningitis, then we go to 2 grams Q12 hours. But for most patients, 2 grams once a day is fine. One other exception is if you have a BMI really high, like over 70, 80, then if you might you can push up your beta-lactam dosing to kind of get a better concentration. So that is another option as well. But usually it's 2 grams once a day, and really sick patient 2 grams Q12.
Right, I think that's a really good point, because whenever I think of the dosing like this, I also think of how big is the patient.
Yeah.
So, and you saw how we talked earlier about the obese patients and how they're high risk.
Yeah.
So you just want to make sure you're not underdosing those high risk patients.
So what are the treatment options for antivirals? So, we have oseltamivir, Tamiflu, which is oral, that we always, outpatient, inpatient, that's what we use. There's, sorry, do you have something?
Oh, no, I was going to say we're not getting paid by any of these companies. So, and that's, I think, something important to say, because, we express our feelings about how we really like this and really like that, but they're not giving us any money for this.
No commercial,
yeah.
Zanamivir, it's an inhaled agent, but it can cause bronchospasm. So it's not ideal for, like, if you have lung disease, if you're on a ventilator, not the best thing to use. Peramivir is the only IV version. It works really nicely. Let's say you have a patient, altered mental status, intubated, they don't have any oral NG place, you can give it orally. So you could give peramivir IV. And so this is really for sick patients. And then now we have the new agent in the play now, baloxavir. So it's approved for over the age of 12. One-time dosing. It works for influenza A and B.
Right, and I really haven't used baloxavir. I think I might have used it once or twice last year, but that was about it. It's approved for adults, and so, but a single dose by mouth, and it may reduce the duration of symptoms by about a day. They might still get a little bit of diarrhea or runny nose, and that's something that would be common. Even in really any medication about we give. No studies in breastfeeding or pregnant, but pregnancy is okay in animal models. I suspect it's going to be okay in pregnancy, and really treating patients for influenza, because influenza can be so devastating to women that are pregnant that it's I would have no problem giving it. Yeah.
The nice thing about, like, now you have 2 options orally. You got oseltamivir and baloxavir. When you have little kids with influenza, it's so hard to make them take Tamiflu for like 5 days. So now we have an agent that you could just take once. And they also recommend this is for uncomplicated influenza. So I picture this used for more of an outpatient setting, and it's one-time dosing. Price-wise, we were just looking it up. It's about $90. So if you're less than 40 kilos, it's 40 milligrams times once. If you're greater than 80 kilos, it's 40 milligrams, 2 tabs, and it's about $90. That's what we found on the internet. I'm sure cost varies depending on the region, but that was around the cost.
And when it comes to influenza, kind of this is pretty much it. I think that patients can get so sick, and we don't really have very many options for them. I've had the question before about, can we give Tamiflu plus baloxavir or 2 things? That's not something I recommend.
Yeah.
I try to keep it, I try to treat sick people with oseltamivir, with Tamiflu as much as possible, and not try to combine things and things. I don't think the studies are quite there yet.
And then I think that you're right. The baloxavir is more for like uncomplicated, and oseltamivir is more complicated. So, I think kind of knowing the difference in those, but yeah,
Right.
I agree with you.
I certainly have the urge to just want to give someone everything, right? Because we don't really have very much in the way of flu treatment. Oh, looks like we went back one. So preventing the flu. So the single best way to prevent seasonal flu is to get vaccinated each year. And so I think if you come away with anything from this talk, I think getting the vaccination is the #1 thing. So good health habits like covering your cough, washing your hands can help stop the spread, or staying home if you're feeling sick or feeling like you might be spreading it. There are also flu antiviral drugs that can be used to treat and prevent. And so we've talked mainly about treatment, but you can also use them to kind of prevent if you're worried, especially in nursing homes, especially in so preventing the flu. Avoid close contact, and we get all of these from the CDC. The CDC has a lot of good information. They have a lot of good flyers or handouts that you can print out for your hospital. So stay home when you're sick. Cover your mouth and nose. Clean your hands. So that's good hand washing. And I cannot stress enough how much it works to wash your hands. It sounds so boring to say, or something that we've heard since we were little, but really cleaning your hands, washing with soap and water is one of the best things that we can do in the hospital. Avoid touching your eyes and nose.
And I think the biggest culprits of not listening to this is healthcare workers. When we are sick, we still come to work, and it's so important for us to protect our patients and our colleagues to stay home when we're sick and get better.
Right. And so, and here, soap and water really goes a long way.
So influenza vaccine, who should receive it? Everyone should get it. High-risk patient, they talk about over the age of 65, chronic diseases, nursing home patient, kiddos greater than 6 months of age, pregnant females, household members, if they're immunosuppressed and they're living in your household, healthcare workers, so we don't spread it to our patients. But technically, everybody should be getting the influenza vaccine every year.
Right, and there are studies that show when people have an infection, they're at higher risk for MIs, so heart attacks, strokes. If someone just has zoster, they just have shingles, within the next 6 months, they're at higher risk for heart attacks and strokes. And that's actually true also for influenza.
Yeah.
So they show that people that get the influenza vaccine, they don't get the same rate of MIs. They have a lower risk of MIs and strokes. And so it's really, everyone should get it, but especially think of your patients with all these comorbidities.
That's such a good point that you said that heart attack. I was reading some studies. If you had influenza, your rate of heart attack is within the next 30 days. It's so high compared to the person who didn't have influenza, same age group. So your mortality in the next 30 days is high due to heart attack. So important to educate our patients about getting vaccine.
Yeah, and I think that's one of the things with influenza. People say, oh, that I'll get over it, but they don't. You need to also think of spreading it to people. And then in patients that have heart attacks, oftentimes we don't make the connection. Well, they had influenza a couple weeks ago, and now they're coming in with an MI, that it's actually a contributing factor.
Exactly.
And so if the patient, is, especially if they're high risk, but patient coming in with an MI or a stroke, if they had an influenza within the past couple of weeks or months, they're at higher risk. So it's really important to make that connection where we don't, if they come in and they have a problem, it may not be the influenza directly.
Yes.
But
so I kind of want to, we pulled this data from CDC. So what are the vaccines that they're recommending this season? So standard flu vaccine, it's inactivated, can be given for anybody over the age of 6 months. Until you're older. 65 years or older, highly recommend doing the high dose influenza vaccine. And that is because, as we get older, our immune system is not as strong and we don't produce a lot of antibodies. So when they did studies to look at how much antibodies do you produce after getting the vaccine, when elderly patients got high dose flu shot, they had better response. So high dose flu vaccine for elderly patient. We also haven't currently in this season, you could also do the nasal influenza vaccine as well. And then if you have severe egg allergy, there's a vaccine that is grown that has no egg component at all. One thing I always get asked is like, well, I have some egg allergy. That's not a contraindication. You could give the vaccine, watch the patient in clinic or hospital for 15 minutes. But if it's a severe egg allergy, then you could use this vaccine.
Right. I think that's flu block, and flu block is very good. So really, there's really no excuse anymore for people to say that they can't get the flu shot.
So just to kind of review who can be vaccinated with the nasal influenza live vaccine: non-pregnant patients 2 to 49 years of age. And then on the next slide, who shouldn't get it: children under the age of 2, adults over 50, pregnant females, people with history of severe allergic reaction to any component of the vaccine, 2 to 17 years of age who receive aspirin, people with weakened immune system, kiddos with asthma, people who have taken influenza antiviral. So, if they just took oseltamivir 2 days ago, and now you're giving a live viral vaccine, you're going to kill the components. So it wouldn't be very good. And people who care for severely compromised patients shouldn't get the live vaccine. So this is who should not get the nasal influenza.
And then chemoprophylaxis. So neuroramidase inhibitors are approximately, so this is like oseltamivir, 70-90% effective in preventing influenza susceptible influenza viruses, and are useful for adjuncts to influenza vaccination. So if someone was just exposed to someone with influenza, and especially someone with immunocompromising conditions, you can consider giving oseltamivir and the shot for those people. So you're covering kind of in the short term with oseltamivir, and then you're giving them a shot as well. So,
and this is especially if you look at the graph earlier, elderly patient and our kiddos who are they get lots of influenza. So if and pregnant females, if they get exposed, it's really important to be aggressive and give them chemoprophylaxis so they don't develop the infection.
Yes, and chemoprophylaxis, one of the big places are like nursing homes, right?
Yes,
yeah. So
of course.
Nursing homes, if someone has influenza there, then it's really important to see, should you be giving it to everyone in the nursing home to try and prevent issues? And the CDC recommends it.
Yeah.
And the CDC kind of sometimes wavers, but I'm kind of, when it comes to nursing homes, I'd rather be on the aggressive side, trying to do everything to prevent it from spreading.
So we have a question. We're under the impression the CDC no longer recommends live vaccine. So they did it a couple of years ago, but if you go read for 2019, 2020, the live vaccine is back in the market.
Right. I think they were showing that people that got the live vaccine, it wasn't as effective, but actually it's back, and they do recommend it now as one of the options.
Another question is, in regards to MRSA coverage for pneumonia, my staff are wondering why empirically recommending doxycycline over vancomycin clinical justifiable. Our antibiogram shows 97% susceptible to tetracycline to Staph aureus isolate.
Yes, that's a good question, right? So,
for me, like, if you have a non-complicated pneumonia and, patient is coming in as a community-acquired pneumonia, and they recently had influenza and they're not in the ICU, they're not intubated, I'm okay with doxy and ceftriaxone.
Yes, so whenever I look at a patient that has an infection, the questions I wonder are, how sick is the patient, and what does our antibiogram show? So if the patient is very sick, just like, you think the same way. Yeah. So if the patient is on a medicine floor, they're not very sick, they're doing okay, and you want to cover, doxycycline is a good option. If they're in the, like you said, if they're intubated, if they're not doing well, if you want to make sure you have everything covered, then vancomycin is a good plan. But whenever we choose antibiotics, just in general, we look at, is it 90% is usually what people look at as the cutoff for saying it's okay to give. The sicker they are, the more you kind of gravitate towards something that's going to be more of 100%. So if they're not that sick, so if they're not that sick, you can consider giving antibiotics that if it's at least 90% on your antibiogram, would be a good option, but if the sicker they are, the more you want to.
Yeah.
So 97% is actually really good.
Yeah. So like, and I also think of it as like when you have, if the patient is stable, it's really easy to like give them ceftriaxone doxy and transition to like ceftonir and oral doxy.
Right.
So like, and you have a plan to go home and they have pneumonia, but they're not really sick.
Mm-hmm.
But if a patient is, on lots of oxygen, BiPAP, CPAP, ICU, step down unit, I think those patients deserve IV MRSA coverage. So Vanco or ceftaroline or linezolid IV. And then you guys could step down to a regimen that is less potent.
And get sputum cultures in those patients. Yeah. And then if they return something, then you can go from there. Yeah.
I wouldn't empirically put somebody on doxy and ceftriaxone if they're in the ICU.
Right. Yeah. Right. So if someone's on a medicine floor, I wouldn't put them on vancomycin. It's kind of,
Yeah. So it's like kind of clinical judgment and seeing how the patient is doing. Great question.
Yeah. Oh, that's a really good question. Yep. So exposed due to a family member. So, and this is what I was talking about earlier. If they're exposed, flu shot and Tamiflu. So you can give them the flu shot and give them Tamiflu, and that will help kind of that patient, because you're giving them Tamiflu, it helps them in the present, and then the flu shot will help them in the future. So in the next few weeks to few months, but especially that flu season.
Influenza vaccine dosing algorithm for children aged 6 months to 8 years of age. If you're less than, if you're 6 months and older, usually you have to do 2 doses. But if you're a child between the ages of 6 to 8 years of age and never received influenza, even after the 6 months, you have to give them 2 doses. Otherwise, once the kiddos get gotten 2 doses, the next year they could just get yearly influenza vaccine. When to take patient out of isolation when you have, and CDC recommendation, and what we do is droplet precaution for 7 days after the illness onset or 24 hours after the resolution of fever and respiratory symptoms. So, watching, like even if the fevers have resolved, if you're like coughing and runny nose, you're still having that virus everywhere and you're going to spread it.
Right. And so sometimes what happens is fever will stop and they'll say, oh, the fever stopped, and they take everything away. And then the next day they have a fever. Oh, the fever's back. And so they put everything back on.
Yeah.
And so if they do that, it's better to leave it on longer than take it off early. So that's kind of.
Yeah. And in my mind, I'm thinking if you're still having all these secretions coming out, that's like there's viruses in there, and that's why you're replicating and you're still infectious. So, don't take them off of isolation in the hospital until you have.
Right. And when I see these patients, then the residents will say, or the fellow, oh, so they've been 24 hours without a fever. We can take everything off, right? And I'll say, probably, but I'm going to wear a mask right now. Right? So, and then I put a mask on because that might be the case. But, when my wife gets the flu, I'll say, I'm sorry, we took him out early, right? Yeah. So, okay, great. So we're happy to answer any more questions. I think so far the CDC with the influenza, it's getting a late start, but it's still important to get your flu shot and make sure all of your family members get their flu shots.
And one of the biggest things that we always get asked in the clinic is when our patients are worried that influenza vaccine causes influenza. So we try to how I always talk to my patients is giving them a personal perspective. I'm like, I tell them I have a 5-year-old, I have a 3-year-old. We all get the vaccine, and influenza vaccine is like, it's not live vaccine when you get the shot, so it's impossible to get replication to get the flu from the flu shot. Another question we always get to is like, this year's strain was different. It's never, only 30%, 40%. Why are we still getting it? So there's actually been studies that show even if the strains are 30, 40% match, it's just, you're priming your immune system to be able to fight when you're actually exposed with the virus, so your body can quickly produce those antibodies to fight the virus. So that's kind of how I talk to my patients.
Right, and it's I try to say the same thing, that if you get the flu, chances are you'll do okay. But if you have a grandmother, grandfather living at home with you, I would feel so bad if I passed it on to them, that you know, I want to do everything I can to say, you know, I didn't pass it on to them if they get sick, and I did my part, kind of. And if there's something, you know, there was a report about if there's something like a home remedy or a tea that could protect as much as the flu shot, that it would be selling out of all the stores, and it would just be selling out completely.
Yeah.
And so, but we have something, and the flu shot is the best thing we have. So. Yep.
Any questions you guys have?
All right, thank you very much for joining. And if you have any recommendations for topics, I think we've had a few recommendations for topics that we're going to look into for the next subject. I think we're going to, but if there's anything that you'd like us to talk about, please let us know. All right.
Have a great day, guys.
Thank you, everybody.
You.